Hello, this is Dr. Ajinkya here. Today I have got a CT scan for you guys, wherein the CT scan belongs to a 67-year-old male patient who presented to us with complaints of bilateral nasal obstruction, difficulty in breathing through both the nostrils. So we got a diagnostic nasal endoscopy done for this patient and saw that both the nasal cavities were having a mass. The mass was smooth in appearance, and we got the CT scan done of this patient. Now, before when you order a CT scan, you always have to make sure that you keep 2 points in your mind. That is, the first being the thickness of the scan, and the second one being the positions of the sections you're asking for. So, the first point was the thickness of the scans. Now, as you can see, this patient's CT scan is of 2 mm. So, normally, to have a better understanding of the neurovascular structures surrounding the sinus area and the bony landmarks surrounding the sinus openings, to have a better picture, we should always make sure that you order a CT scan ranging from 0.6 to 1 mm. Max to max, if possible, you can order a 1 with 2 mm scans, but not beyond that, so that you can have a better understanding. It would be always better to be having a scan which is 1 mm, which is the ideal thickness for the CT scan. Second point being the sections, that is, it should be in all the three sections, that is the coronal, the axial, and the sagittal, so as to we can study the disease or the pathology from all the sides, and we can have a near 3D anatomy for a better understanding. So we got the patient's CT scan done, and which I'll explain you in some time how to exactly understand the basics in reading a CT scan of a patient with a suspected case of a tumor, which could be a benign or a malignant, depending on the findings on the CT scan. So to be on a safer side, we got this patient's biopsy done, and the biopsy report came to be as a case of nasal histiocytosis. Now, this is very interesting to know that this patient is 67-year-old male patient. That is, he's an elderly patient, and this patient came to be as a positive case of a nasal histiocytosis. Now, nasal histiocytosis could be of various types. It could be Langerhans cell histiocytosis, it could be Langerhans cell sarcoidosis, it could be a Langerhans cell histiocytosis, or the second variant could be ROSAI-DORFMAN disease, that is the commonly called as RDD, that is a ROSAI-DORFMAN disease. So, the patient's histopath report suggested that this case is a case of ROSAI-DORFMAN disease. Now, what exactly is the RDD? Now, it is a case of a cervical lymph node involvement wherein the WBC, a type of WBC cell called as a histiocyte, is excessively produced in excessive numbers, which get collected within these very cervical lymph nodes, causing it to enlarge and giving a boggy, enlarged cervical lymphadenopathy. Normally it is nodal, that is lymphatic, but sometimes it could be extranodal, so it could have extranodal spread as well. So in that cases, it can go to the central nervous system, the bone, the gastrointestinal tract, the renal system, and the nasal area, orbit, and the paranasal sinus areas as well. So it is very rare to find a case of a nasal histiocytosis, extranodal nasal histiocytosis, and that too in a patient of age group more than 60. Normally, if you find a case of extranodal ROSAI-DORFMAN disease, it is normally seen in patients ranging from the age 15 to 20 years, which is kind of a young age. So it is very rare to find a case of ROSAI-DORFMAN disease in an elderly patient. So we were lucky enough to get the CT scan and the biopsy report for this patient. Now, the ROSAI-DORFMAN disease is considered to be as a benign pathology. So the treatment options for this case are the surgery for you can excise the entire nasal mass from bilateral nasal cavities, Second thing, you can send him after the post or after the surgery for the chemotherapy and the radiotherapy. The medical management for this patient is the use of steroids, prednisolone in tapering doses, oral injections, IV, whatever suits the patient's prognosis. Now, this case does have a relapse. If you operate on the patient and after few months the patient can come back with a case of relapse or a recurrence with the same pathology he was having previously. So you have to make sure that you operate the patient, completely excise the mass, and send the patient for chemotherapy, radiotherapy, and start him on steroid doses. Now, sometimes the disease itself is self-remitting, but if in cases where the disease is kind of exponentially growing and it is beyond the confines of normal prognosis, it could be life-threatening. So you always have to keep a follow-up on these patients so as to have a better understanding of the prognosis. So in such cases, you always have to make sure that the differential diagnosis also plays a very important role. Now, the major disease which becomes a differential diagnosis in case of ROSAI-DORFMAN disease is the Langerhans cell histiocytosis. Now, these both are variants of histiocytosis. Now, you can how can you differentiate between a Langerhans cell histiocytosis and a ROSAI-DORFMAN cell histiocytosis disease? Now, the most important thing here is the immunohistochemistry. In case of the ROSAI-DORFMAN disease, the S100 plus marker is positive, the CD68 marker is positive, and the CD1A marker is negative, which is completely opposite in case of Langerhans cell histiocytosis. So that's one way of differentiating it on the basis of the immunohistochemistry. So today the aim of this video is to show you guys how to read a CT scan in a suspected case of a tumor. So wherein the anatomy of the nasal cavity and the paranasal sinuses is completely distorted, and in that distorted anatomy, how you can identify the exact structures, whether this is the anterior ethmoidal artery, the anterior ethmoids, or whether you have entered the posterior ethmoids, where are the limits, where is the lamina papyracea, how the transition from the anterior to the posterior occurs, where the sphenoid starts, where exactly is the osteomeatal complex, the septum, whether it is destructed, eroded, everything. So certain anatomical landmarks you have to keep in mind before you read a CT scan. Now, let's start with the very first scan on this image right here. Now, as you can see, or as I always keep on saying, all the CT scans have this image on the top left corner. Now, this is called as a scout view. Now, there are two views. One is the gantry view, where is the anterior posterior facing image of the patient's bony anatomy over here, and the other one is a scout view, in which there is a lateral aspect of the patient's bony anatomy depicting the thickness of the scans. So basically this is a scout view, the very first image, the scout view. And moving on further, as we all know, this is a frontal bone. The white bright structure on CT scan is considered to be as bone. So this structure which you see here is a frontal bone, below which you can see two separate nasal bones with the internasal suture. This vertical segment you see is the septal cartilage, and these two lateral structures are the nasal ala. As you keep on going posteriorly, you can see the frontal sinus coming in the view. So, and this is the interfrontal sinus septum. So this is the right frontal sinus, this is the left frontal sinus, this is a nasal bone, this is the septal cartilage with the nasal nares. So as you can clearly see here, this side of the frontal sinus is completely opacified with a little bit of erosion you can see in the interfrontal sinus septa. and minimal collection on the right side towards the floor of the frontal sinus is easily visualized. So as you can see here, the interfrontal sinus septa is eroded. You cannot say it is completely destroyed, but yeah, it is eroded. As well as the same time, you can see the floor of the frontal sinus anteriorly here is also minimally eroded. It is not completely destroyed, as you can still see a thin segment of bone lying around here. So this is a case of a partial erosion of the floor of the frontal sinus and the interfrontal sinus septa. So as we move posteriorly, you can further see the erosion of the floor of the frontal sinus becomes more prominent. And see here, this area of the interfrontal sinus septum is minimally eroded, and a major erosion you can see towards the floor of the frontal sinus on the left side. So the entire left frontal sinus is full of opacification, with minimal opacification on the right side of the frontal sinus. As you go below, you can see this is a nasal bone. This is a perpendicular plate of the ethmoid in picture, and these two long processes are the frontonasal process of the maxilla with the septal cartilage, and this is the area near the lip, the skin of the lip. That's the lip area. So you can see the interfrontal sinus septa eroded, the floor eroded. Over here the floor is also eroded, with opacification in the nasal cavity on both the sides. As you can see, there is opacification on both the sides. Normally this should have been completely black, which is the presence of air, but here it seems that there is a collection in the area of both the nasal cavities. As you move behind, you can see the floor of this frontal sinus seems to be completely eroded on this side, the left side, with minimal bony erosions near the area of the frontal beak, and the left frontal sinus being completely opacified, with minimal opacification on the right frontal sinus. And the beak is still intact, so this is still the area of the frontal sinus. Now, as I always say in the videos, whenever the floor of the frontal sinus, whenever the floor of the frontal sinus, as in this case, this is the floor of the frontal sinus, is intact, it is still the region of the frontal sinus area. Now, in this scan, as I can show you, still the frontal floor, which is formed by the frontal beak, which forms the floor of the frontal sinus, as well as the anterior wall of the frontal sinus, is still intact over here. So this still is the region of the frontal sinus area. And as you can see, this is the interfrontal sinus septa, the perpendicular plate of the ethmoid, the bony septa, and see the entire nasal cavity with minimal normal gap seen. This entire nasal cavity is opacified, with the right frontal sinus still having a minimal opacification. Now, if you can closely see on this region over here, this is the interfrontal sinus septum, and there is a one incomplete septa arising from right frontal sinus. This could be the area of the interfrontal sinus septal cell opening up into the right frontal sinus, and the beak is still intact, so we are still in the area of the frontal sinus. Now, as we move posteriorly, you can see the area of the opacification. This is the posterior most aspect of the frontal sinus. Now, still on the left side, I can see the frontal beak to be completely intact, and on the right side you can see a thin bony margin, suggesting that still the beak is intact. So this is still the area of the frontal sinus, the perpendicular plate of the ethmoid, the nasal septum, the frontal process of the maxilla, the nasal cavity being completely opacified still. This is the appearance of the maxillary bone, the origin of the maxillary crest area over here. So you can see this is all soft tissue opacification, suggesting that there is presence of a nasal mass bilaterally. Now still the frontal beak is intact, so we haven't yet reached the area of the frontal recess. Now, what is frontal recess? Why am I stressing so much on the frontal recess and the frontal sinus? As long as the frontal beak I can see on the CT scan, we are still in the area of the frontal sinus. Now, as soon as the floor, see in this scan, as soon as the floor of the frontal sinus, which was made up by the frontal beak, is no more visualized, as in this scan over here, this depicts the area of beginning of the frontal recess area. So this is the area of the frontal recess where you no longer see the frontal floor formed by the frontal beak. So this depicts the start of the frontal recess. Now, what is frontal recess? Frontal recess is an area posterior to the frontal sinus. I repeat, frontal recess is an area posterior to the frontal sinus wherein the frontal sinus drains. So frontal sinus is quite anteriorly. So as we could see over here, the frontal bone, the frontal sinuses, the left one being majorly involved. So frontal sinus, beak still intact, frontal sinus, the beak is still intact, and in this scan the frontal recess starts. So see, anteriorly is entire structure of frontal sinus, and as we go posteriorly the frontal sinus drains into the frontal recess. Now this was the area of relation of the frontal sinus with the frontal recess. The moment the floor is gone, starts the area of the frontal recess. Now as we reach the area of the frontal recess, okay, towards that, this is a frontal process of the maxilla. Frontal process of the maxilla. Just keep on following the frontal process of the maxilla. You can visualize the nasolacrimal duct system. Now, just follow this instrument. You can see this area over here. This opacified area over here. Yeah. So this is the area of the nasolacrimal sac and the nasolacrimal duct region. As you can see here as well, this is a region of the nasolacrimal duct system. So this is how you can visualize the presence of the nasolacrimal duct. To make it easy, just keep on following the frontal process of the maxilla. See, this is a nasal bone, this is a frontal process of the maxilla. Keep on following that, just keep on following that until you see a soft tissue opacification on the lateral aspect of it, posterior and lateral to the frontal process of the maxilla. So this was the posterior most region of the frontal process of the maxilla. Just posterior to it, you can see a vertical area of opacification. This is the area of the nasolacrimal duct system. Okay, so this is the nasolacrimal duct. Now, we all know the nasolacrimal duct drains into the inferior meatus, which is present 1.5 centimeters posterior to the anterior end of the inferior turbinate. So this entire nasal cavity, you can see it's completely opacified. So normally it becomes very difficult to differentiate between the middle turbinate, the inferior turbinate, the uncinate process, the osteomeatal unit. So in this case, how and what are the basics where you can easily identify the structures well within? So you just have to follow the bony landmarks for that. Now, first we could assess the relationship between the frontal sinus area and the frontal recess area over here. Second, we just kept following the frontal process of the maxilla, and we could see the area of the nasolacrimal duct system. This is the nasolacrimal sac area. This is roughly the area of the superior and the inferior canal, the common canaliculus. This is the nasolacrimal sac. This is a nasolacrimal duct going through, which opens into inferior meatus. In this case, the inferior meatus is completely opacified, and this opening through which the Hasner's valve guards the opening in the inferior aspect, the inferior meatus, which is at 1.5 centimeters posterior to the anterior end of the inferior turbinate. So this is how you identify the nasolacrimal duct system. Now, the moment you see the nasolacrimal duct system, you keep on going posteriorly. Now see, this is the area posterior to the nasolacrimal duct system. Now, the second thing in identifying after the area of the nasolacrimal duct system is the agar nasi. Now, normally, if you keep on following the frontal process of the maxilla like this, you reach for the nasolacrimal duct system, and the very first, you can see over here, you can see over this cell over here, the very first pneumatization in this region, just near the region of the nasolacrimal duct system, is the agar nasi cell. So because of all the opacification, the anatomy is kind of distorted, so it's difficult to identify. So I can see here one cell, the anterior most cell. This is the agar nasi cell. Now, what is agar nasi? Agar nasi is basically nothing but the pneumatization, pneumatized anterior ethmoidal cell pneumatizing the lacrimal bone. So this, the area of the nasolacrimal duct system, just the very first pneumatization, the very first cell you see in this region following the frontal process of the maxilla posteriorly, that's the agar nasi cell. Okay, so that's the agar nasi cell. The agar nasi cell is the anterior boundary of the frontal recess. Now, as I said, this is the beginning of the frontal recess. Very anterior to the frontal recess is the presence of the agar nasi cell. Now, as you keep on going posteriorly, you never leave your bony landmarks. Once you follow the bony landmark, it becomes very easy for you to identify all the structures within reach. So, here you can see the level of the cribriform plate. That is the Crista Galli I'm showing you right now. Now, what is Crista Galli? Crista Galli is nothing but an upward bony projection, a diamond-shaped projection of the bony anterior cribriform plate, okay, which gives attachment to the falx cerebri in the center. So the falx cerebri attaches to the Crista Galli in the midline, and the base of the Crista Galli roughly measures the area of the perpendicular plate, the bony septum in the midline. So this area is still the area of the frontal recess, the posterior aspect of the frontal recess, anterior to which we could see the agar nasi cell over here. So if we keep on going posteriorly, this is a proper frontal recess area, the drainage area of the frontal sinus. This is a cribriform plate starting over here. So this entire region is completely opacified. We are not able to see where the inferior turbinate is, the middle turbinate, the various structures. It is very difficult to visualize the nasal septum as well. Now, as you can see, you can follow the base of the Crista Galli over here. It is having a slight deviation to the left side, and you can follow this area. So you can see this bony thing over here. That's the nasal septum, and that is the maxillary crest where the septum attaches. This is the maxillary bone. So the septum is having a left side deviation, probably due to the mass on the right side nasal cavity, pushing the septum to the left side. So at this stage, we can say that only a thin bony septa is visible in this region and this region. So at this stage, we can say that the septum could be eroded, but can be confirmed only intra-op. So far we have assessed the frontal sinus, the recess, the frontonasal process, the agar nasi cell, the nasolacrimal duct system, the septum deviation towards the left side, the cribriform plate, the Crista Galli, the posterior most aspect of the frontal recess. This is the frontal recess proper, anterior to which was the agar nasi cell over here. Now this is the orbit. This is a medial orbital wall. That's the lamina papyracea, which seems to be intact. There is no soft tissue continuation from the nasal cavity into the orbit. So we can safely say the lamina papyracea is quite intact. There is no dehiscence or no erosion at all. As we keep on moving posteriorly, you can see that this is the area of the frontal recess, the cribriform, the Crista Galli. There's one cell we can see appearing in this region. Now, as I can show you, now in this scan, this was the area of the nasolacrimal duct system. Okay, and this scan, see, this is a very beginning of the maxillary sinus. This is the beginning of the maxillary sinus. If you keep on going posteriorly, you can see the maxilla appearing. That's the maxilla. You can keep on going posteriorly. This is the maxillary sinus. This is the maxillary sinus. Maxilla, maxilla. This is the maxilla, maxilla. So this was the very beginning of the maxillary sinus over in this region. The left maxillary sinus being completely opacified. The right maxillary sinus is having one abnormal cell. Now, what cell that could be? Now, that is the Haller cell. Now, this cell you can see over here, which is opacified a bit. This cell is a Haller cell. Now, this cell is a Haller cell. Now, what is a Haller cell? Now, Haller cell is yet another anterior ethmoidal cell which pneumatizes the lower floor of the orbit. That is, it is infraorbital in nature. So this cell over here is the Haller cell. Now this is the orbit. Now this is below the orbit, so this is infraorbital. And this Haller cell, why is it very important to know the Haller cell status on the CT scan? So that whenever you're operating on the patient intraop, it is very essential that you remove this very Haller cell, because this Haller cell, if pneumatized, can push the maxillary opening inferior laterally so that it can hamper the drainage area of the maxillary sinus. So if you have to open the Haller cell, you have to remove the partition wall in between so that the Haller cell communicates to the maxillary sinus and it's not blocked anymore. So that's the significance of the Haller cell over here. So that's the, see, you can see this is a sinus on the left side, completely opacified, but it is, the area is big, it's huge, it is not blocked anywhere. As you can see, you can compare the sinus on the left side, the right side sinus, this is the sinus opening and this is the Haller cell. If you go posteriorly, you can see this. This is a separate cell area altogether, and this is blocking the area of the maxillary outflow. So it is very important to remove the Haller cell intraop. As you can see over here, that's the Haller cell, the posterior